Great. So now we have time for Q&A, and I have a whole list of questions here that have been sent up. For those of you who don't remember, I'm hoping he'll put the slide back up on how to do the questions. But in the meantime, so basically it's go to peds.cnf.io, pick out the session Peds 21, and then you can write in your question. It would be really helpful, most of these I can figure out, but it would be really helpful if you could put in which speaker the question is aimed at. I'm going to start with Dr. Grossman because there's a lot of questions on information on long-term consequences of these kinds of problems in children. Are there studies? Have they looked at things like maternal relapse, depression, incidents of foster care for the kids? So I think the question is wide open. Anything you want to talk about related to long-term consequences would be fantastic.
This is working? Yes? Great. So that's a great question. That's the question for neonatal abstinence syndrome at this point. We're doing a lot of stuff to work on the hospital stays and things like that, but the big issue is what happens long-term. And the short answer is we're not entirely sure at this point. This has been a difficult population to follow long-term. We want to know how are these kids doing as toddlers and as adolescents and as they grow up. And we just don't have the data yet. There has been a big push sponsored by the NIH and everybody to try to figure this out now. So if you could just hold that question for 10 years or so, then we'll get a better answer. But that is really the key thing, and that's again the stuff in the hospital is hopefully, we should have the mindset of how do we set these kids up for success, and we just don't know what the impact of the actual opioid is and the environment, which everybody has discussed. We don't have those answers yet. What we do know that separating babies and moms is a bad idea, so that's the one that at least we've tried to not do. Which I don't think is that controversial. But that question should be asked by anyone who speaks on this topic, and we will get better answers. We just don't have them yet.
So a couple of questions for Dr. Osterhoudt. One is, how do we get state monitoring programs to be nationwide? Because right now, one of the big problems with state monitoring programs is that they're limited to that state. So if you have a license in that state, you can go to their programs and look up who's gotten what. But for example, I practice in California, and we have a lot of patients who come in from Nevada, from Oregon, from Arizona, from other states, and we can't look up where they've been getting medications. Is there a push to do that, do you know, or is there a way that could be done?
Yeah, I think that would be an ideal circumstance and something that a lot of people would love to see. I see it firsthand. I work in Philadelphia. Philadelphia geographically is right on the border with Delaware, right on the border with New Jersey, and it's easy to go to each of those places. I remember when I was younger, I took a trip to Australia and I was on a train, and when I went from one state to the other state, I had to get off the train because the gauge of the train track was different. As we look at our electronic health records, right, and we want to see what happens in other places. And so unfortunately, in our rush to put Band-Aids on problems, we have done a lot of these projects in a wide range of areas in medicine is kind of individual products or our own community products. And so I think that there is a big push to try to make all of these things work together and to speak together, but like everything else, it takes time, money, and attention, and we're not there yet.
Tomorrow apparently is National Drug Take-Back Day, and then I want to mention, because I know that there are lots of take-back locations in lots of pharmacies. I think both Walgreens and CVS have committed to taking back controlled substances. Those can usually be found either locally or going through the DEA or the FDA websites. Sorry, there's a lot of questions here, so trying to figure out which ones to ask is a little challenging. I'm trying to lump a few of them together, so excuse me for that. Two questions for Dr. Gonzalez. One is, should pediatricians prescribe buprenorphine? And how do you motivate
know who's
teens
asking that.
that have a substance abuse disorder to enroll in treatment? Because most of the time they refuse.
So the first one's easy, yes. And for a multitude of reasons, one having to do with, so I work with two major groups in my clinic. One is that's focused specifically on emerging adults. So that 18 to 26 set, they're the hardest to retain in treatment, so the biggest challenge. And then the other is kids below 18. I'd say it average about 15 or 16 years old. It's very different for a pediatrician to be providing that care and in a pediatric appropriate setting than it is for somebody who's, internal medicine or some other person who really just does not view the treatment and care of the child with the developmental lens that we do. The other part is just to increase access overall. For people who are not familiar with the wavering process and what it means to be a buprenorphine prescriber, you can get wavered and prescribed once or never. You're not all of a sudden trapped and have to fill a practice, even though, I'd be perfectly happy to have it be just that. But you can decide how you're gonna work that into your practice. I have people right now within our department who, on the inpatient unit, they're merely getting them induced onto the medication and then sending them off to me. So you have control over how you utilize this in your practice. At minimum, please, anybody who has a DEA license and can apply for this, do the waiver training. It's free through the AAP site. So yes. And then the second part was about, I heard refusal of...
Refusal. How do you motivate a teenager with substance abuse disorder?
Number one is sign up to participate in that ECHO cohort, either 1 or 2, 3, or 4, because part of it has to do, you're in it in the long haul, and it's another reason why pediatricians need to be involved in this. We have long-standing relationships with these kids and families, and it's not done in a single visit. And remember that the most important thing is maintaining that relationship with them and getting repeat visits. It might take some time, and I think that's part of the problem. We feel such an urgency, and we kind of in our head know the right answer, but there's no area in medicine where they just really kind of just do what we say. And so it is gonna, and it does mean, even though it's painful, getting in there and realizing that for some kids, this is gonna be, it's gonna end up being a long process. Some kids are able to, get to some resolution earlier. Some of them, it's gonna be a few years. Some of them, it is gonna go on to be chronic. And so it's getting that mindset of maintaining the medical home with you and working on transition to adult care when you can no longer work with them anymore.
Yeah.
I
was going to say that waiver, right, seems to be a big barrier for a lot of us. Oh, I don't want to sit and get my ex waiver and go on. 1, it's really educational. 2, it's really pretty easy. But I think from the policy standpoint, all the pediatricians in this room, gone to medical school, done residency, been in practice for varying periods, right? And during that time, we get very little training on opiate receptors and prescribing these drugs that are so dangerous, but we need this waiver to use the drug that treats it, right? And so I think the next big policy step is to remove the waiver.
Yes.
There are a number more questions on the neonatal abstinence syndrome. How do we support moms? How do we engage moms? And is there any data on NICUs that have rooming in for the mothers versus separate spacing in terms of outcome and treatment?
Sorry, what was the first one was?
How do we support
Yes.
mothers who
So-
may or may not be, and some of it was the concern about being on multiple substances and if they're really able to actually care for the baby.
Yeah, so there's a couple of scenarios. There are certain scenarios where the mom is not going to be involved. They're delivering and leaving, and that's it. And the way that we look at that and caring for the baby, it doesn't change what the baby needs. Baby still needs, it's hokey, but the treatment for this is mostly love. And so we need to figure out how to provide that and get them to somebody who's going to love them full time as quickly as possible. So if your mom isn't going to be there, the solution is not to keep you in the hospital away from somebody who's going to care for you for 3 or 4 weeks. It's to get you there maybe even faster. So that's the one part. In terms of supporting moms, it starts prenatally. It starts with understanding what the role is in caring for the baby, prepping them with parenting support groups, parenting classes, all those kinds of things. Any way we can wrap around the families to provide support. It's not just in the hospital. It has to start earlier. They have to know. What we're finding is with the shorter length of stay, it's much easier to have families stay. So if we're mostly having the kids stay for 5 to 7 days. If you had a C-section, you were there for 3 or 4 days, and so you were prepared for that. So most people can figure out how to do it, and if it means having your other kids be in the hospital too some of the time, we will adjust our rules for that kind of thing. But we need to start prenatally, and that's what we have. They meet with social workers and with nurse practitioners beforehand to understand what their role is, and then setting them up with as many services as we can find and that the state can provide and that other services can provide. And there are quite a few if you start digging up, at least in some parts of the country.
There's another question around urine tox screens.
Mm-hmm.
If they are not, there's several questions on this. If they're not picking up synthetic opioids, are there alternative tests we should be using? And there's an additional question that says, how do you find out? If you are assuming you're sitting off a urine tox screen and you think it's gonna pick this up, how would you know as a practitioner what your urine tox screens actually are going to pick up and not?
I don't have a great answer for that. I can say that we don't use the baby. There's a couple tests. You can do a urine test, you can do meconium, you can do cord blood. And meconium will give you the longest view of what's been going on. If we know there's been some exposure, we start treating those babies aggressively from birth, which is, it does not mean medication, but we start all of the non-pharmacologic stuff immediately. And if we see a baby that we didn't know had an exposure and we start to see signs of withdrawal, which we have, if you're now really anywhere in the country, most everybody's familiar with those. And if you have no knowledge of it, most likely that they're not in a program, and then you're going to see the withdrawal a lot faster, then we just start our treatments. And so we don't actually do much with the testing, to be honest with you. So there'll be other folks have found. I know there's a study from Ohio where they found that there were kids that they didn't identify who they might have done something differently for. But I think it's mostly. This goes back to starting this process early. It's really about trying to get this less stigmatized, being able to discuss this with your doctor if there's usage that you're not, this has to change, this is a big change, but how punitive it can be if you are even using prescribed opioids makes it so it is in the self-interest of the mom to not tell anybody, and that needs to change.
And I'm going to throw the question open for Dr. Osterhoudt and also Dr.
Yeah,
Gonzalez.
I think the urine drug screening kind of depends on your setting, right? In the emergency department setting, I consider opioid poisoning to be a clinical diagnosis that you can look at the patient, see CNS depression, respiratory depression, small pupils, give them naloxone and they wake up, and you fix them in 1 minute's time, right? When you're looking at neonatal abstinence, that's also a clinical diagnosis to some extent. When you have a child who presents with a horrible illness and it's unknown, or if you think that there's some psychosocial aspect of the family that you need to investigate and the information would inform you, then it does behoove you to know what's on your test. If you work in a hospital, it should be as easy as picking up the phone and talking to your clinical lab supervisor and asking them. All of the lab tests that they have a package insert that can tell you exactly what it finds and what it doesn't find. At my hospital, we've added on a separate test for methadone and a separate test for oxycodone. So when you get the report, it actually says opiates negative, oxycodone negative, methadone negative. We still don't routinely test for buprenorphine, and we don't find fentanyl. In the fentanyl epidemic, more and more places are thinking it's important to put that in. The place where this testing is really important is when you decide to start treating people with Suboxone or other types of opioid use disorder, when you really want to look at habits in diversion, in concomitant substance abuse, where even better testing is important. And it's tricky. A revolution is coming. Hospitals are catching up. There are now fentanyl test strips you can do as a point of care. They're easier than a pregnancy test. If you're working in office practice and you're sending out to a commercial laboratory, it's the same thing. It's a phone call or checking the website of that commercial laboratory, but it is worthwhile to know.
Okay. I'm sorry. I thought Dr. Gonzalez was going to say something about that too. With the moms that are breastfeeding, and if they are currently still on opioids, do you worry about transmission across breast milk? I know it's pretty minimal, but
Yeah, there's transmission of everything through breast milk, and so pretty much, and so there will be transmission. It's a very small amount. Outcomes for babies who are breastfeeding with NAS are better in all of our measurements. That is something we encourage breastfeeding. There used to be, and all of the breastfeeding organizations will encourage it. There's no, if you're in a stable program, and so we will actually advise, say, look, if you have a relapse and you start using heroin again, you should probably stop breastfeeding at that point. And if you are using lots of other things, but generally, if you're in a program, and we're definitely going to encourage it. And some will get through into the breast milk, but not a significant amount.
there's several questions around the use of marijuana in children, and particularly because in many states it's legal now, although of course we all know it's not legal for children. It doesn't matter. I mean, adolescents in particular will say, oh, but it's legal, it's safe. How do you counsel patients? How do you counsel mothers who are pregnant? There's increasing evidence about mothers smoking marijuana while pregnant. And then, of course, you see them in the ED as well. I'd be really curious to see what you all think about that.
Yeah, so the baby one, we don't see withdrawal from it, so there's nothing special to do. It's just whatever how your hospital policy on breastfeeding is, and there's quite a range as this data comes out of it seems to be a concern if there's longer term marijuana use, maybe less if it's infrequent. But in terms of the afterwards caring for the baby, there's nothing special. It's really just breastfeeding advice.
I'd say continuing on from there, I think part of what tends to happen, right, the first 1,000 days and then the adolescence are right, the biggest important developmental growth periods. And that's also the time that we mostly think about substances. The problem is, it's that time in between that we really need to be educating and having discussions with parents. So part of what happens is we kind of just leave this until either the parent drags the kid in when they're 16 and says, I want them pee tested. That's a little late in the game. Or something else that comes up. They're just otherwise they're suspicious or concerned. And so the time to do it, to think about it, there are so many other things that you give anticipatory guidance on, and parents have their own values and plan of attack figured out. They need the information. So we need to educate ourselves first and then have conversations with parents earlier. It becomes, so there's a lot, as you know, there's a lot of debunking to do. There's a lot of debunking to do with many of our colleagues too, who have gotten to a place where they think it's not only super, super benign, but maybe I read in, I don't know, BuzzFeed that this is a treatment for something. I'm like, really? Is that where you get your scientific information for everything else? But it is, it's been a lot of the propaganda campaigns have been very effective at polarizing people on this. So it's educating our colleagues, educating ourselves, and having those conversations with the parents before the kids even know what substances are, so they can figure out their platform and engage in conversations with their kids before even we do. And yeah, when it comes to kids, it's harder. I think especially if you're getting into conversations with a teenager late, especially after they've already started using, it's very important to be balanced. I mean, I've been studying a lot of the internet sources and then looking at things like Night a Teen and stuff like that. And the bias is very clear. There's a bias towards selling this stuff, and so they don't look at the negative consequences, or on the medical side, where we're just trying to be blind to the fact that there are experience benefits that people have. And even if part of that is just fun. And so we have to be very validating. And as you know, teenagers have really, really sensitive bullshit detectors. And so if all you try to do is say to them, no, it's bad, then you've lost them. And so it's, like I said, it's remembering to have very balanced conversations, and it might take quite a while. When they're putting out a pros and cons list, their cons list is very short or empty. So it takes a while.
So that is, so we're done with the Q&A session. We have a 30-minute break for people to please, please, please go and look at the posters. As mentioned, there are some great posters out there. We'll reconvene at 3:30, and we'll start with Dr. Reynolds, who's going to talk about an experience caring for a patient with addiction issues and also get some words from the patient's point of view. We'll then go on to acute pain treatment, chronic pain treatment, and integrative mind-body techniques. So please come back, please view the posters. I'm sure our wonderful speakers will stay around to answer, because there were a lot of questions on this list. It's a little hard to try and get through all of them, and I apologize if I didn't ask your particular question, but hopefully the speakers will be able to answer them for you now. Thank you.